Well, good morning, everyone. I'm Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. As usual, we'll go ahead and get started with some reminders, logistics, and then introductions for today. Please be sure to join us next week. We will have the talk, Top 10 Things You Should Know About HIV Medicine in 2025, and that'll be given by Dr. Melissa Murphy. I'm here at Providence St. Vincent Southern Auditorium. You can often find us here live on Tuesday mornings at 8 a.m. for Grand Rounds. We are also occasionally live at Providence Portland at noon. Of course, you can always join us on the Teams Live platform. And you can earn CME credit for being here in the room, for watching live virtual, or by watching a recording of the event. That recording is the same link as the Grand Rounds invite, and that will also always let you know if we are meeting live in person. I will go ahead and hold most questions to ask as time permits at the end, but please post any comments or questions that you have during the talk, and we can always clarify in real time if need be. And now to introduce today's speaker, I am joined by Dr. John Dussel, a practicing vascular surgeon with Oregon Vascular Specialists. He is a fellow of the American College of Surgeons and board certified in both general surgery and vascular surgery. Dr. Dussel earned his undergraduate degree in biology at Boston College while also competing as a Division I distance swimmer. He completed his medical degree at St. George's University and his surgical residency at Waterbury Hospital, followed by specialized vascular surgery fellowship training at the University of Connecticut in Hartford. Dr. Dussel's philosophy centers on fostering strong relationships between the vascular care team and patients, ensuring that each individual receives comprehensive and compassionate care. We are so grateful to have Dr. Dussel join us to teach us today.
Thank you, Dr. Lacher. So I don't know if you guys have been appraised of the changes in vascular surgery, but just in my 7 years of practicing independently and over the last 15 of practicing, it's really gone from a all-encompassing field to very specialized training. And so with that elevation, there has been a boutique style of vascular surgery that has popped up. And so what I want to do is really define what the practice is, where the patients are not only best treated, but how they're best treated. And so modern vascular surgery, and the bougie way that we're doing it now, is taking these patients, the correct patient, doing the correct workup, and then tailor-making a procedure for them. Namely, putting them in the right location. And so to further define the specialty, I'm going to go through a broad swath of the population and then parse it down, and then do the broad swath of the treatment options and parse those down. So for the meaning of this talk, it's going to be mostly endovascular surgery. So defining our patient population. Vascular disease is ubiquitous. Vascular disease somewhere is vascular disease everywhere. And so when you have patients who present with signs and symptoms of atherosclerotic disease, we really need to define where they're going to be best, who is going to be best served and where. So for instance, you have first case is going to be a golfer, an older person who comes into your clinic and says, you know, I'm trying to make it all 18 holes, but I have to, you know, stop every 50 yards on the fairway and my leg hurts. Alternatively, you have a second case where you have a person who has long-standing diabetes, hypertension, basically your classic patient to be seen in the outpatient setting, over 50. And they now have a neuropathic ulcer of their great toe. And finally, a third case where you have a patient who presents to the ED, hasn't seen medical attention in their entire life, comes in with a calcaneal osteo on MRI. So for that first case, to keep this didactic, I'll do the workup myself. We see these patients in our clinic all the time. And one of the most important things we do in vascular surgery is vascular medicine. Medical management is the mainstay of therapy for every patient across the board. Without medical therapy, any intervention will fail. And therefore, ensuring best medical therapy for vascular patients includes not only regular checkups, but an antiplatelet agent of some variety, a statin medication. The LDL goal is less important for my team. Max dose is what we would suggest. Blood pressure medications, diabetic medications, tobacco abstinence. Again, I counsel my patients that anytime tobacco is in the ring, it's like Muhammad Ali. It'll knock you down every single time. There's no question about it. I can't do anything to beat tobacco or time, really. And then a graduated walking program. And so this patient who comes in and can't make it their 18 holes is going to get a stern talking to, a pat on the back, and a lot of new meds. And then we can talk about what happens at their follow-up. Our third case, calcaneal osteo. We have a very intimate relationship working with our podiatrists. And I picked this case because there's really no salvage. Once you have calcaneal osteo, unless you present with a incredibly robust history and in the setting of trauma to receive that, there's really only baloney amputation as an answer. And so case 3 is going to represent someone who the best option for vascular surgery is going to be a baloney amputation. The issue in these sorts of patients, and the reason why amputation carries with it such a high morbidity and mortality, is not actually the procedure. The procedure itself is 45 minutes, but it is life-changing. It's actually personally one of the best procedures I do. I take it incredibly seriously. I think it's one of the ways that we can immediately change someone's life, to take them out of the sick role, something that they've been dealing with for such an extended period of time, to put them into an acute phase and hopefully on the road to recovery. But the issue is that the patient comes in with all the disease that they're going to lead with. Morbidity and mortality of amputations is entirely because of the comorbidities that they brought into the operating room, and that will complicate everything following. You have two basic populations when it comes to amputations. You have the young traumatic, and you have the old and debilitated. These are not the same populations at all, and demographic data conflating them makes it incredibly difficult for anyone to get real diagnostic data, long-term data on amputation rates, because the person who comes in with a traumatic amputation following a car accident, who was a long-distance runner beforehand, it's going to be a long-distance runner afterwards. But the person who's got calcaneal osteo because they've been resting their foot in a decubitus position while they've been smoking and uncontrolled diabetes is going to have the heart attack, is going to have the stroke and the MI following the procedure. And so case 3 is going to be just an amputation. Now case 2 is where it gets fun. This is where the vascular surgeon can actually not only change the long-term outcome, but the life. So as long as we've got a surgically optimized patient, a medically optimized patient, and a patient who can be surgically optimized, we talk about critical ischemia, and that's this grading scale. Our gold mine here, the place where we're going to be able to do all of our work, is going to be somewhere between severe claudication and minor to major tissue loss. And so that family is our Rutherford 3 through 6, where we can find the correct patient to do some sort of intervention for limb salvage or life-saving therapies. This is a patient I did yesterday. Patient had tissue loss, but had tissue loss in a salvageable way. Great toe that was broken down. We also do this for rest pain or life-limiting claudication. When I say life-limiting claudication, that's a very specific diagnosis. It's not our golfer who puts the pressure on in clinic and says, I really want to walk. I really want to walk. But I just can't do it. Well, your ABIs are 7. and you do have a short segment occlusion, there is something that we could do for it. However, it starts you on a treadmill, because any of the procedures that we do that are minimally invasive trade a long-term outcome for a short-term fix. And so when we do these minimally invasive procedures, we are buying time for their claudication to resolve through collateralization. Our patency rates on endovascular procedures range between 12 months and 24 months, depending on the patient. What we are doing is buying them the opportunity to walk themselves out of this problem, because it will come back. There are two things that we can't fight: tobacco and time. And there will always be time on the clock. And so finding that correct patient for the procedure is important. The workup. So once you've identified your patient population, ensuring that they are the correct patient for whatever you're planning to do is key. Medical optimization we talked about, and then the physical exam. I had one of the best mentors I've had said, anybody with diabetes that you can't feel a pulse needs some sort of imaging. Now, when she was practicing, that was a direct stick angiogram through the spine to the aorta. Very different world. We have an ultrasound now, which is fantastic. And if I can give any piece of advice to the younger generation, getting phenomenal at point of care ultrasound is our new stethoscope. Use the stethoscope. It's great. However, point of care ultrasound is going to be the way that you differentiate yourself from absolutely anyone else as far as diagnostics go. You don't have to be good at it, but repetition and continuously evaluating with your own ultrasound will further identify patients who you can help. And so I think that things like the physical exam, where you find that you do not have reliable pulses, and then an ultrasound is going to be the bulk of the workup that's going to be needed in order to ensure that the patient is correct for the procedure. Now, the correct procedure. This is myriad. You can have a million different ways of treating these things, but we are tending towards a more minimally invasive approach, namely because vascular patients are as if God spilled a person and we're trying to bring them back together. So trying to keep the amount of insult from any intervention on the physiology while also doing the most good is the balance that we're trying to reach. The alternative is open or endovascular. Primary open procedures are still the mainstay of why vascular surgeons are who we are. And then endovascular procedures have become a way that we can mitigate the physiologic insult required in order to revascularize someone. Then the place that we do it. When I started my training, I only worked in the hospital setting. We do have multiple different modalities within the hospital setting. However, there are multiple locations where the expediency of the patient's care is the priority. And so whether that is in the operating room, in the cath lab, or in the outpatient setting, we're trying to balance timeliness, access to care, and patient experience. If a patient has a terrible experience, they're not going to want to seek medical attention again. And so we're trying to really take the whole patient and treat every part of them. There are certain things that can only be done in the hospital setting. Specifically, the common femoral artery is like hallowed ground for us. If you ask any vascular surgeon, their favorite blood vessel in the entire body is the profunda femoris. With that, having inline flow from the heart, you can save a leg, you can save a life. Without the profunda, you cannot do anything for this patient. And because of where the profunda is, because of how it interacts with the vessels around it, if that is threatened by anything, we're like mama bears. You don't touch our profunda. If it goes anywhere near there, it's a big problem. And so that hallowed area of the body in my opinion, unless there is a very compelling reason, which it would need to have some certain gravity behind it. There is no intervention for that in the minimally invasive setting. And the maximally invasive setting, the one incision procedures that we can do for this can alter someone's life. As far as distal bypasses go, they're only going to be able to be done in the inpatient setting as well. And then there are advanced endovascular therapies. So we have the stuff that's old school, the stuff that's super new school, and both of these need to be done in a highly monitored setting to ensure not only that the patient has good outcomes, but also the team has good outcomes. When you talk about advanced endovascular, we're talking about extreme amounts of case planning, preparation, and technology. One of the best things about being a vascular surgeon is you get the coolest toys. We get the best things. And so we are able to, it sounds like science fiction, we're able to use radiation and essentially advanced intelligence to create these 3D models within computer systems. And through our radiation suite, we're able to completely reroute all of the blood vessels in the body. It's wild, but because of that, you're incurring large amounts of radiation for not only the surgeon, the patient, and the team. And so to be able to do this safely is something that can only be done with fixed imaging systems in a team setup, which is what we have in the operating room as we do combined procedures. And then there are, well, this is a very moving case for me. It's because when I moved out to Oregon, it was because the Venn diagram between neonatologists, which is what my wife is, and vascular surgeons is this hospital. That's it. There's one place. And so we came out here together, and it's been a wonderful 7 years. And in those 7 years, we've shared one patient, neonatology and vascular surgery, and this is her. She was a 31, she is, excuse me, she is a 31-year-old female who came in with preeclampsia and had 4-centimeter renal artery aneurysms. There's no place for this woman besides the hospital. She's also 29 weeks at this time. So neonatal, OB-GYN, family medicine, us, and then urology as well, because she had a couple other things going on. All came together, and over the next 5 weeks kept her in observation, getting weekly MRIs. And it came to the point where she was getting ready to deliver, and the 4 teams were all in the operating room at the same time. So baby came out well. The renal artery aneurysms bilaterally got coiled and did fine, and they're both still happy and whole. But that cannot be done anywhere besides a tertiary referral center with an incredible amount of resources behind it. Phenomenal outcomes only could be done here, I think. To that point, having patients with large amounts of comorbidities or high acuity, the hospital setting is going to be the only place for them ever. This patient is someone who had a massive, a submassive PE and a massive DVT, which you need ICU, pulmonology, you need hem-onc, and then for us to clear out the patient's lower extremity as well as lyse the clot in the lungs. Again, another success story, but it can only be done with a multimodal and group practice. And then we come to endovascular therapies. So we don't have the patients who have claudication or such extreme tissue loss that they need amputations. We have patients who have salvageable vascular disease. And then we have patients who need something done, but do not need the team approach, don't need the open surgical approach, are looking for something in the middle. And that's where endovascular shines. Now you're going to deal with endovascular patients mainly because we're not the only ones who do this. It's cardiologists, it's interventional radiologists, it's interventional nephrologists. There's going to be an interventional rheumatologist soon, I'm sure. There are so many people working in this space, and so I'm sure that you guys are going to have to deal with patients who have a endovascular therapy at some point. And so the most common stuff that we want to review is the ways that these procedures are not only planned, but executed. The most common arterial approach is through the femoral system. The femoral system is this really great area, at least as far as access goes. There's nothing between skin and artery besides muscle, or besides, there's nothing between skin and artery besides fat, which can be a problem when you do open surgery, actually, because there's nothing between the skin and the artery. If there's an infection, it just goes straight down. And so then you need to put muscle in between, but nevertheless, it is an easy access point for arterial access. And the femoral system generally tends to accommodate large bore catheters. So now the catheters that we use range anywhere from 4 French to like 26, 28 French when we're doing advanced aortic disease. It can accommodate quite a bit, but knowing what you're getting into beforehand really helps. And that's why this system is so good, because what we always do as far as surgical planning goes is to ensure that when we fail, we still fail well. And the idea is that if there were to be complications, how are we going to fix those complications? We think about that in the third order, even when we're getting access. And this area specifically is really useful for that, mainly because it's easily accessible. And if everything goes wrong, if everything is, if somehow there is a massive problem, the only thing that you need to do to ensure that you have the time to plan the next step is put pressure on that area. And because of where the femoral system is, it accommodates that really well. The important part of this is because the important part of locating the femoral bifurcation specifically is because, again, we vascular surgeons, we love our profunda. If you get near that with a needle, we get near you with a needle. It's a very simple concept. However, because of patient size or alternative factors, namely where the bifurcation is, if you're not appropriately using ultrasound to get access, you can get into trouble. Namely, you can access one of the other femoral vessels, the superficial femoral or the profunda. And the issue is that the common femoral breaks up into those. And so you have an immediate decrease in the diameter by half. And as I'm sure we all remember from physics, if you decrease the radius by half, it's actually to the 4th power that you're decreasing the size of it. So immediately you shut down a leg, really. And so that's why when we're trying to obtain femoral access, we use the point of max pulsation. However, the most important thing is using ultrasound guidance. It's good for point of care. It's, I would say, malpractice if you're not using it to gain access, namely because this trial has been out since 2010. Faust trial evaluated whether or not you needed ultrasound in order to safely access the femoral vessels. You do. It's as easy as that. Point of max pulsation is a nice idea, especially if you're trying to gain access quickly. However, in our patient population specifically, but in all patients, because of the variability of the bifurcation of the profunda and also ongoing disease, you can get into trouble very quickly. Again, the issue is that vascular disease somewhere is vascular disease everywhere. So if you're doing an intervention on someone's left calf, they're not just going to have vascular disease in that left calf. They're going to have it all over their body. And therefore, if you access a vessel that's diseased, you're going to get more disease. Namely, you're going to shut down the vessel and then they're going to call us. And so we use a modified Seldinger technique. I said I dictated modified Seldinger technique for maybe 3 years before I had actually understood what modified Seldinger technique was. This is just anecdotal. I think it's really interesting. They used to take spinal needles and stick them through the posterior into the aorta, and they used to have a catheter around it. And so what they would do is they'd stick the thing in, take it out, you'd get blood shooting back, and then they would do their lower extremity angiograms through the spine, not through the spine, sorry, adjacent to the spine, but through the aorta. Like we put TVARs in for less. But nevertheless, the modified cellular technique is where you actually access it with a needle, put a wire in, and then put your catheter over, which is what we're demonstrating here. The A is the through and through technique. That's something that our anesthesiology colleagues normally do on the radial art lines. That is a style preference, and in the radial, they can do it. When you're using an ultrasound, it is a lot easier to just access the anterior wall instead of going through and through. And one of the complications in the femoral system, because of where you're accessing it, if you do go through and through, namely how A is set up, you can get a retroperitoneal hematoma. So hiding 2 liters of blood is really, really hard, but it can be done in the body in a couple different places: the abdomen, the leg, the chest, onto the street, and the retroperitoneum is the other place. And so when you guys get these patients back from the cath lab, and the heart's being funny, and the blood pressure's dropping, and the heart rate is through the roof, and you can't really figure it out, retroperitoneal hematoma is something that's kind of slept on, but can be a very real complication of femoral access. So like I said, we access with a needle. It's generally a 4 French, and then we use our wires. Now wire technology, if you're a nerd, this is such fun stuff, and if you're not, you can tune out for the next 2 minutes, because I just absolutely love this stuff. They're designed, they look like a coat hanger. It looks like nothing but extruded metal, and in reality it has a core, a handle, tapers, shifting, the ways that they can manipulate wires to accommodate not only the heat from the body, but the lubricity, the way that it interacts with blood. Like, it's just mind-blowing what they're able to do. But the reality of it is it's a long stick. It's a long stick, and we use that stick with different things on the tip of it to ensure that we're not doing damage. I mean, that's the first goal, right? Try to not make it worse. And so after you gained access, you put in your wire, and generally the first 2 centimeters of your tip, unless you ask for specific wire, will give you the generosity of bending to identify certain characteristics on ultrasound to make sure that you're not running into trouble as you're getting in. Because what you can do if the wire is too stiff is it can be used exactly like a stick and poke either through the vessel itself or into areas that you don't want it to. Namely, we want the wire to transition through the flow lumen so that we can improve the size of the flow lumen. Sometimes it's so small that it takes up too much space for that wire. And so we have multiple different size wires, including the 035 is our working wire. That's generally how it goes, but we can go higher if we need to put in stiffer devices. And it can go all the way down to 0.014 as far as how small these wires get. There are extremes on both sides. You can get specialty things, but really the keys that you guys can be looking for in the op notes are things from 035 to 014, and that's going to be the bulk of the wires that we use. There are 2 real ways to think about the wires. It's either like a search or a working wire. And so when we're trying to find our path, that's where we're going to be using the really simple, soft wires so that they can actually navigate. It's kind of like a salmon. They just kind of navigate through the areas of rocky terrain through the flow lumen. And then once you're in your correct position, you exchange that for a working wire, which is a coat hanger. It's about as hard as it gets. And so our frequently used wires include things like the Benson wire, which is that soft wire, glide wires. Lunderquist is your workhorse. That's going to be as hard as it gets. And the way that we exchange those out is for equally sized catheters. Again, the catheter system is exactly the same, and as you can see, they come in all kinds of varieties. Namely because if it was easily navigated through, I mean, anybody could do it. So that's why we have access to all kinds of different tools in the process. The reality of it is it's just a tube for you to exchange your stick. Yep. And so they're either selecting catheters, guide catheters, or flush catheters. But realistically, you go in, you take your picture, that's a flush catheter. You select, that's your selecting catheter. And then there's the guides, which if you can't just get there easily, you use something with a different direction on it. It helps you. And then once you're in correct position, you start your procedure, and that's used through sheaths. So you're not damaging everything on your way in every single time. And so the sheaths go anywhere from 4 French to 28 French. But once you've got a sheath in, which is basically the big tube through which all of this goes, you can do your procedure. And that's trying to take what is the flow lumen and make it bigger. Plain old balloon angioplasty, or POPA, is what was classic. Actually, before this, when they were shooting, dye through spines, they used to do something called daughtering the lesion, which is where you just essentially take a long pipe and push it and crack all this stuff. It didn't go great, namely because what you were doing while you were essentially snow plowing through the blood vessels was not only providing radial force, but anterior force. And so once you took that out, all the blood flow returned, and you got these dissections, which is where the blood gets into the medial space and shuts it down distally. And so what we need to do is find a way to get the plaque out of the way, but not push it downstream. And so that's when balloons came in. Fogarty came up with this great balloon idea where he put it on a long tube. He's selling wine now, so he's doing just fine. But the balloon technology started in the 90s and has been progressing ever since. We have various types of balloons that we can use. Our drug-eluting balloon technology is where we take cancer drugs, attach them to the walls of the balloons, and then push them into the walls of the vessel. Not only are you cracking the plaque within the wall of the vessel, but you're also decreasing the neointimal hyperplasia that comes with essentially really ticking off the blood vessel. It's a useful tool. However, it has not borne out in the tibial space. So this is really good for things like the femoral system. If you don't want to leave a stent, which we don't. We want to give as many opportunities for these people to have minimally invasive procedures as possible before needing something like a stent, mainly because the failure of a stent versus the failure of a balloon are two totally different things. When you fail with a balloon, you just get regrowth of disease. When you fail with a stent, the whole stent goes down because it's no longer a part of the normal system. When you have things like dialysis and you get recurrent neointimal hyperplasia, you get these areas that are so incredibly scarred that we have these things called Atlas balloons, where normally you can bring up a balloon to, like, your burst pressures on these balloons are like 12 millimeters of mercury. And so that will accommodate most blood vessels. These balloons, these Atlas balloons that go in for the dialysis patients, they go up to like 40. It's just mind-blowing the amount of pressure that's put into these balloons. And it's because when you have scarring over and over and over and over again, you need more impressive pressures to open up that scar. But you can also use cutting balloons, which are really, really cool. They sound like kind of ninja things, where you have like 4 long stripes of razor blades that you slide into, open up, and it creates grooves so that the scar opens up. And these are primarily used in that circumstance. But once you have exhausted your balloons, plain old balloon angioplasty, drug-eluting balloons, and you're getting recoil on your balloon angioplasty, you have to move on to the next step. Now, when you're in this procedure and you're doing your angioplasty, what we look for is recoil. The blood vessel itself in these patients is the adventitia, the media, and the intima. The intima is generally pretty safe. the media is where all the disease process is, and then the adventitia holds it all into place. And so when you do a balloon angioplasty, you are cracking that media. Hopefully, because of the radial force, you're not cracking the intima, and so you get remodeling in the wall as opposed to showering downstream. So you got this like mesh barrier inside this big chunky block of blockage, and then the adventitia holds everything into place. It can go wrong in a bunch of different ways. Namely, the calcium can be transmural, which means that it goes from the intima to the adventitia. When you crack it, you get blood out of the vessel. It's not a great thing. And you have to do something in order to accommodate that. We'll get into that in a second. But if you're just moving the muscularis layer, that middle layer, and the plaque isn't changing, well, when you take your first shot, you've got plaque in the way of the flow. You do your balloon, and you get good balloon expansion, and then you release the balloon, you take another picture, and it looks exactly the same. It means that the patient has been accommodating this based off of the muscularis layer. And so what you need to do is move the plaque as opposed to crack the plaque. And so that's what a stent is designed for. It's, again, if you want to go real nerd on this, YouTube nitinol. It is such a cool metal, a nickel titanium alloy. It's phenomenally good for humans. And the reason is because it's got a melting point just in the vicinity, not melting, but sorry, a structural integrity temperature point of about our body temperature. And so what it will do is when it's cold or when it's super hot, it's very malleable. But when you put it into the body, it changes form. And so you can contort these in all kinds of crazy ways. And then you put it into essentially our body heat in ex vivo, and you can see it come back to its original form. It's very, very cool. But it's the nickel titanium alloy, and they use a matrix that basically looks like a mesh wall. And the structural integrity of it is based off of the inner cell design. Normally, these are self-expanding. They offer a lot of flexibility, whereas the balloon expandable ones offer a lot of strength. And so they can be a little bit more on the steel side versus the nickel titanium alloys. But nevertheless, if you want a balloon for a very specific area, namely to ensure that you don't get into the profunda, you want to put it exactly where the superficial femoral artery takes off. This is your best bet. Whereas those the ones that conform to the body shape can be a little bit more variable in their application. After you put in your stent, if it's not balloon mounted, you balloon it after the fact, and this is essentially what I was describing. So you have a media that's accommodating, you have a pre-deployment, and then once you put in the stent itself, the stent now makes up the location of the intraluminal blood flow. In those patients where they have transmural plaque or they have complete occlusions, and you do your balloon and the artery like falls apart essentially because now you've got extravasation blood going out of the blood vessel as opposed to being contained within your dissection, you use a covered stent. Covered stent, anybody who's had a Gore-Tex jacket, it's the same stuff. It's just extruded. One of my favorite stories about this material is that apparently some like the vascular surgery journals from the 90s and early aughts were basically like sartorial journals. They were all about like velours and all kinds of substances that we could use for bypasses, because the holy grail is like a bypass that we can use that is on the shelf, inert, and doesn't cause an increase in infection, which they all do. But this vascular surgeon and his buddy were sitting at like a table at a regatta, and this guy had just gotten new sails on his boat. Super relatable, right? So he's sitting at the table. He's like, "This stuff is so cool. It wicks anything." He took mustard and poured it all over it, and it just wicked right off. And he's like, "Bypasses, awesome." And so they started extruding it at sizes of 6 millimeters or so, and then we used them for bypasses. They worked great, and so we started putting them on stents, and that's where we get the Viabond. The Viabond, for you political nerds, that's what they use to essentially reconstruct Dick Cheney, all of his aneurysms, every single, the guy's 80% Viabon. I'm pretty sure that it's like a Darth Vader situation where he's just like comes down in a pool of Viabon. But it is internally mounted on an external scaffold, so it provides not only a decrease in the amount of endothelial damage, because you've got it removed from the process, but it also allows for a lot of flexibility, which is why these are kind of the ones that we go to for the knee. There is another kind of stent called a supera, and you're trying to balance structural integrity with flexibility, which is really, really hard from the physics of it all. The knee moves in 180 degrees one way and 270 in the other. And so having it contorted and also coming back to its shape, so we've got that cool nitinol metal, but also the structural support from the Gore-Tex extrusion is super useful, especially in those patients. We did have drug-eluting balloons and stents. The self-expanding silver PTXs were used for a while. They're fine. And so the other side of the ways that we can reestablish flow channels and hopefully keep foreign bodies out of the body are atherectomy devices. Now, there are specific types: directional, rotational, or orbital. And you do have a measurable change in the luminal disease, especially when associated with drug-eluting balloons, because what you'll be able to do is not only take away some of the plaque, but also expose more of the media, which is causing the inflammation, to the drug-eluted balloon. The Silverhawk is a directional device. As you can see, it actually has a gatch that pushes it up against the wall, and we use it like a snowplow to bring along the disease, and we get these huge ribbons of plaque that come out, which, if you've done an endarterectomy, that's a really gratifying procedure. You pluck it out, you put it on the back table, blood spurts are very great. This, it's like you have to like bring them out, but it's also about a third of the time, and it also does exactly the same thing. So less gratifying from a procedural standpoint, but an incredible workhorse, specifically in the infrainguinal space, so the femoral system or the tibial systems. As you can see, that's essentially it open and snow plowing part of that plaque off. A lot of good studies about it. The laser is also extremely cool. You can use it in the advanced endovascular setting to burn holes into grafts to allow, if you've if you're trying to do a TVAR in a patient who has some sort of subclavian issue, you can actually use the laser to burn through the Gore-Tex and put a stent into the aorta from the arm using the laser. But we've actually started using it in the infrainguinal space as well to debulk the lesions and accommodate more stents and wires. One of the issues is that when you're doing this procedure, the wire can be the size of the lumen. So it's being held together by literally 0.014 inches of material. And so once you have a wire down into true lumen and you've ensured that, getting a stent past all of that is like trying to take that up 5 sizes. It's either really hard, or you run into the same problem that you ran into with the daughtering the lesions. You just push everything down. And so what you can do is create a conduit through the plaque that you are treating, which will then accommodate the stent later. And that's what the orbital laser is for. It creates a lumen the size of the laser, so a 3.5 to a 5 French, and will accommodate anything after that. And if any of you guys have seen me work on a Monday, you know that what will regularly happen is you'll get behind the plaque and then you'll be stuck in the media. And normally what that would mean is now we have to do a bypass. But we have other options. These are crossing devices where if you're stuck outside of the lumen and you know that you're going to put in that Viabon stent now, Well, all you need to do is do an internal bypass. And so what you do is you take the location of your catheter, ensure that you're going in the correct disposition with either your IVUS or the intravascular ultrasound, excuse me, or your radiology evaluations, and send a wire into the true lumen below the lesion, or catch it from below by going up. It is very difficult to use, and I don't like it, but it's very useful as far as people who can do it correctly. Cryoplasty is something that is interesting, and at the beginning of my talk, I said I wouldn't talk about things off-label. This is going to be off-label very soon because it doesn't work. The reason that we use the femoral as our preferred place is because of closure. It's kind of like hiking in that way, is that you pack in and you pack out. Everything that you plan to do during it, you need to make sure that you have an exit strategy. And so the femoral system is great for the exit strategy because at the absolute worst, if everything goes to pot, you can just pull everything out at home pressure. This is every medical student who comes into my operating room gets the same speech. There are two things that you can do, that you can learn in this operating room that can demonstrably save a life anywhere in the world. One is how to ventilate. So watch the anesthesiologist figure out how to understand chest rise, because that is the A of the ABCs, and then bleeding. Bleeding is number two. And so the only thing that you need to know for anything besides junctional or internal bleeding is pressure. One finger of pressure, you can save a life, period. That's how you stop bleeding. Whether it's from a gigantic aortic sheath or whether it is from a small puncture from an A-line, direct pressure in the correct position, you can hold that forever and you can save a life. And so the gold standard of closure is compression. The FemStop, if you get one of these people who get delivered to you from the floor, do not trust the FemStop. I've never had a good experience with this tool. I am sure that there are phenomenal cardiologists, interventional radiologists, and IRU nursing staff who can use these with magic. It has never worked for me. And so if your choice is between putting this on and holding pressure for another 15 minutes yourself, put on a podcast. Just hold pressure, because this thing, it hides so much evil. The issue a lot of the time is that it gets placed into the incorrect position. And so what happens is you have a puncture site on the skin. And so your thought, which is completely appropriate, is that the needle goes directly down. We use a 45-degree angle because we use trigonometry every single day. This is something that my 5th grade math teacher would absolutely adore hearing. I use Pythagorean theorem every single day to calculate the entry. The issue is that the point of entry of the needle in the skin and the point of entry in the needle in the artery are different. So if you affix this directly to the top of where the patient is bleeding from, you're missing it by 2 centimeters. And so what happens is you put pressure distally, so you've occluded the outflow. So all the blood is going directly up and underneath. And if you've backwalled it, back into the retroperitoneum. FemStops, I'm sure they have their utility, but I would be extremely cautious if one of these was dumped onto your service without getting to the bedside and looking at it. Because what can happen is bleeding. And if the bleeding is controlled, then you get things like pseudoaneurysms, which is what can happen specifically in the superficial femoral artery. Now, what will happen in that circumstance is you're not putting pressure in the correct location again, but because it's too far down, you can't. It's not possible. The way that the superficial femoral artery moves in the muscle, it moves in space. And so you're not putting pressure against anything unless it's a common femoral artery stick, which is why things like this happen. We have closure devices, which we routinely use. Our go-tos include the Minx and the ProGlide. These have various ways of being defined, but the way to think about it is that ProGlide device is basically just a surgical suture. MINX device is just a collagen plug. And so the angioseal or MINX device, they are two different sides of the same coin. You have a foot plate that goes into the vessel. It catches the vessel, holds it up, and then you push down the collagen plug on the other side. So the whole device goes in, you get bleeding from the back end, you deploy the foot plate, bring it up, and then put the collagen plug down. Angioseal has been one of the mainstays of small access surgery, especially in the endovascular world. MINX, same thing, except there is no foot plate in the vessel itself. It's just a balloon. That does allow you to see it under X-ray. And so what we'll do is we'll put contrast into the balloon. And so if you've got an incredibly rocky common femoral and you don't want that foot plate to catch against something, well, you use the MINX and you can actually see the balloon come back and get into the correct position. The only issue is that once you've removed the MINX device, you've lost access to it, or yeah, you've lost access to it, and also the pressure is only from the outside. You don't have that sandwich. Star close and per close are basically two different ways of affixing a surgical suture to the vessel. Star close uses metal, but this is for our large bore catheter access, meaning that you can essentially put these in, and anything up to like a 21 French can be closed using external devices. Again, you put the device in, put the foot plate on, the suture comes around and through, and then you just suture it down. The complications come from foot plate maldeployment. Again, you can see them threatening my profunda there with the foot plate right up against it. And routinely, this is where we get into trouble. A low stick or a high bifurcation will make it a little bit more difficult for a safe deployment of a ProGlide. And then you get occlusion of the outflow vessel, which regularly, because these patients are so debilitated as far as their vascular disease goes, it takes a while for them to realize that the SFA is occluded. In your young population who have spry vessels, they'll wake up in rest pain. But when you have a patient who's got severe, long-standing chronic disease, they can go weeks without figuring this out. And so all of those endovascular procedures are what we are now doing as far as the Oregon Vascular Group goes. We are still working out of the Providence hospitals. We have a person on site every day and 4 on Fridays. But we have started to offload a significant number of elective and semi-urgent cases to our office-based lab, mainly because we have the correct workup, the correct patient, the correct diagnosis, and now we have an opportunity to expedite the care with the appropriate treatment. So I'd love some questions if you guys got them.
Great. Thank you so much, Dr. Dessel, for some understanding of, wow, the complex tools available at your fingertips. Have some online, but I'll take a look and see if any question in the room here. I'll go ahead and get us started while people think on that. So many of us in the room are internal medicine doctors. Leg pain is very common and quite complex, and as much as we wish, whether the diagnosis is claudication is not always as obvious as we would hope. Can you talk a little bit in your experience about the history, physical exam, and maybe specifically like which type of vascular study you find most helpful to maybe have looked at and worked at before they see you?
Yeah, okay. So, I mean, the easiest, most cost-effective, safest is going to be just a pulse exam. Abnormal pulses in anyone should prompt some sort of diagnosis or diagnostic follow-up. The most useful one is going to be a vascular ultrasound, is arterial lower extremity bilaterally. that's going to give you not only the ABIs, which you can do in the office, but we don't trust, which no shame to anyone, but it's that is more of a subjective finding when it comes to our diagnosis. What we want is a dedicated vascular ultrasound, because they will have a probe on the vessel itself while the blood pressure cuff is increasing, see the vessel, hear the vessel, have some sort of data for us, which is really, really, really useful. So the simplest way to identify inpatient or outpatient, do they have a pulse? If they have a pulse, then it's very unlikely to be a vascular issue. And even if it is a vascular issue, there's not a lot. I can't improve on a good pulse. So the idea would be, okay, so there's a little nuance, but nevertheless, the key is, do they have a pulse? If they don't have a pulse, vascular ultrasound. Once you've got that, you will be able to at least drop it into the camp of, okay, they have blood vessel disease and need further workup, or they don't have blood vessel disease, leg pain can be coming, or they don't have arterial blood vessel disease, leg pain can be coming from the spine, the nerves, the diabetes, the hypertension, the end-stage renal disease, or they don't have arterial, maybe they have gigantic blown up legs with elephantiasis, they might have venous stuff.
Yeah, can you please speak a little bit to access to graduated walking programs, sort of what we have available here in our community, whether that's accessible to patients, how successful they are in engaging?
Well, okay, so I think that's a very disparate question. How successful they are in engaging is a really challenging one. That's like smoking cessation. Like, we have the tools. Interestingly, Alex Perez started up a program before COVID. COVID hit, shut down, it came back. We have, there is Medicare money for graduated walking programs. So they can come in person to the Heart and Vascular Institute over at the base camp. They can get training sessions, they can get programs, like it's available in Epic. So if it's not, I don't order it regularly, mainly because all of my patients have already failed that. But nevertheless, there is a Epic question, and if not, Alex Perez is our vascular medicine doctor who does the bulk of this. And so if it is claudication and it's being managed by someone other than the vascular team, that's where I would go. Yeah.
Great, thanks. We often lean heavily on Dr. Perez's expertise for sure. So
yeah, no, he's fantastic. Yeah. He has changed the way that I think about a lot of vascular medicine. And I mean, as far as nerds go, we speak the same language. And so it's very fun to work with him and see what's in the pipeline. All right, it looks like we're approaching 9 o'clock, so we will call that a morning. Thank you, Dr. Dessel. Thank you.